Well, welcome to Medical Grand Rounds. It's a pleasure to have all of you join us today. Today, I'd like to introduce Dr. Joyce Lee to you. Dr. Lee is an associate professor of medicine in our division of pulmonary sciences and critical care medicine. Dr. Lee directs the program in interstitial lung disease at the University of Colorado. She received her bachelor's and her MD degree from Northwestern University, and her BS degree was in medical engineering. She went on to house staff training at Northwestern and then did her pulmonary fellowship, pulmonary and critical care fellowship at the University of California, San Francisco. UCSF recruited her to stay on as a faculty member, and she was an assistant professor of medicine focused on interstitial lung disease and was supported through a K award there. We were fortunate to recruit her in 2015 to the University of Colorado to lead and to develop and lead our program in interstitial lung disease, and to further develop her research career in interstitial lung disease. She subsequently received a K award from NHLBI, National Heart, Lung, and Blood Institute, and is in the process of transitioning to an RO1 award focused on early indicators of rheumatoid arthritis-associated interstitial lung disease, a very common form of pulmonary fibrosis that affects many individuals with rheumatoid arthritis. Joyce has done a superb job in developing the interstitial lung disease program at the University of Colorado, and she is a terrific educator as well. So I really look forward to this Medical Grand Rounds where she's going to teach us about interstitial lung disease. Joyce, it's all yours.
Thank you, David, for that nice introduction, and thank you for the opportunity to share with you several advances that have been made in our understanding of interstitial lung diseases. Here are my disclosures. And here are my learning objectives. So the goals of my talk today are to recognize that interstitial lung disease and pulmonary fibrosis are not specific diagnoses, but to approach the diagnostic workup of these groups of conditions using a multidisciplinary fashion. And then finally, to describe some general treatment approaches for a particular type of pulmonary fibrosis called idiopathic pulmonary fibrosis. So here's an outline for my grand rounds today. I'll start with a case, one of my first cases when I arrived here in 2015. And then I'll share with you why I think people outside of my ILD community should care about interstitial lung disease. And then I'll cover key points in diagnosis, treatment, and research. And then I'll conclude with some information about our ILD program. So the case is that of a 54-year-old male who reported decreased exercise capacity. He was a previous triathlete and reported that he was just not getting as much benefit from each breath. On further questioning, he did state that he had a dry cough that started a few years ago, but hasn't really changed that much. On review of systems, he reports aches and pains in his elbows and knees, but nothing that sounded particularly inflammatory. His past medical history included hyperlipidemia, a hiatal hernia, reflux, and Barrett's esophagus. He had no surgical history, and his current medications included omeprazole, melatonin, and a multivitamin. He had no family history of pulmonary fibrosis or other autoimmune conditions. Socially, he smoked 1 to 2 cigarettes per week for about 3 years in the 1980s and no significant secondhand smoke exposure. He denied any environmental exposures to birds or molds, and he worked in software sales and was married with 2 children. On physical examination, he was afebrile, blood pressure was 141/82, heart rate 60, breathing 16 times a minute, and saturating 95% on room air. On exam, he had bibasilar crackles, but otherwise had a normal physical exam. His lung function demonstrated a forced vital capacity of 4.51 liters, or 85% predicted, which is considered normal. Total lung capacity of 5.91 liters, or 80% predicted, again within the normal range. and his diffusing capacity was 20 or 53% predicted, which is moderately reduced. And then on 6-minute walk testing, he desaturated from 95 to 85% after ambulating 1,000 feet. And here are images of his CT scan. So you can see here, these are prone images, and in the upper regions of the lungs, his lung parenchyma looks pretty normal. But however, as we advance into the chest, you can start to see subpleural and peripheral reticular opacities and some traction bronchiectasis. Oops, sorry about that. And then these reticular opacities and traction bronchiectasis abnormalities increase as we go into the mid and lower regions of the lungs without significant ground glass. So the radiologic interpretation of his CT scan was basilar and subpleural predominant reticulation and traction bronchiectasis without definitive honeycombing. He did not have mosaic attenuation or air trapping on expiratory images, and the radiologist classified this pattern of disease as that of probable usual interstitial pneumonia or UIP pattern. He had some blood tests that demonstrated a normal CBC, chemistry panel, and liver function tests, and he had some screening serologies, which were all negative or normal. This patient had actually already had a surgical lung biopsy by the time he saw me for a second opinion. And what you can see here on the left-hand side is a low power view of his lower regions of the lung. You can see the pleural surface, if I can use my mouse without advancing, right here. And there's a lot of dense subpleural fibrosis, and the staple line is up towards here. You can also see evidence of microscopic honeycombing in through here with mucostasis. On higher power view, you can see this really beautiful pentachrome stain where you see this bluish hue here. This is representing a fibroblast focus. So the histopathologic interpretation of his surgical lung biopsy was that of usual interstitial pneumonia. So after review of his case at our multidisciplinary conference with pulmonary radiology and pathology input, this patient was subsequently diagnosed with idiopathic pulmonary fibrosis, or IPF. This is one of the most common causes of lung fibrosis that we see, and it's characterized radiologically and histopathologically by this usual interstitial pneumonia, or UIP pattern of disease. It involves men more than women, former smokers more than non-smokers, and it's a disease of the aging population. So this patient was a little bit unique in his early age of presentation. The usual age of presentation is in the late 60s. The average survival from diagnosis is pretty dismal, 3 to 5 years following diagnosis, leading to 40,000 deaths per year. And the course of IPF is unpredictable. So some patients can have a steady decline in their disease over time, as someone would be on panel or on line C. But others can deteriorate pretty quickly after diagnosis and die within a year after diagnosis. And yet others have more of a stepwise decline, being characterized by periodic acute exacerbations, ultimately leading to death. For this particular patient, after we gave him his diagnosis, he was started on treatment with nintedanib, which is an antifibrotic, and this led to symptomatic, physiologic, and radiologic stability for approximately 2 years. Unfortunately, he started to decline and developed an acute exacerbation of his disease 3 years following diagnosis. You can see the representative CT scan and how significantly his fibrosis had changed at that point. He was hospitalized with hypoxemic respiratory failure, requiring VA ECMO support and subsequent lung transplantation. And now he's almost 2 years post-lung transplant and doing well. So now I want to step back from the case and really share with you why I think you should care about interstitial lung disease. And so there's 5 major reasons why I think people outside of my field should be aware of these conditions and know about them. So the first thing is that IPF, this disease that I just shared with you, is a serious condition. You can see the incidence rate of idiopathic pulmonary fibrosis in the red bar compared to other serious diseases. And perhaps not as common as leukemia, it is certainly more common than pulmonary arterial hypertension and MS. The other reason to recognize this group of diseases is that we're observing an increased prevalence of these conditions over time. So the top bar graph, demonstrates incidence in the red bars and prevalence in the blue bars. And you can see each year there's a steady increase in the prevalence of interstitial lung disease over time. Further, I explained to you already that IPF is a disease of the aging population. We see many more cases in those aged 65 years of age or older, and as our population ages, we're only expecting to see even more cases of idiopathic pulmonary fibrosis. Finally, and probably far more worrisome, is the increasing mortality that's been observed over time. So this is old data, but still relevant, that looked at the number of deaths for men and women and age-adjusted mortality rates for men and women over time. And there is an unfortunate and steady rise in deaths over time. And finally, in terms of how this affects our patients, not only are they dealing with a disease that's uncommon and leads to significant mortality, they are burdened with lots of symptoms. Cough, shortness of breath, and fatigue are day-to-day experiences for these patients. You can see here in data that was published just a couple years ago that in general, their health-related quality of life across all the domains of an SF-36 health-related quality of life questionnaire are reduced. And in the months prior to death, these health-related quality of life scores really plummet. And finally, the last reason I think it's important to be aware of this is that there are numerous delays in diagnosis. And, you know, our disease, as many of you know, we have a lot of strange terminology, a lot of acronyms, a lot of names that don't make a whole lot of sense, which leads to delays in diagnosis. Other reasons for delays in diagnosis include nonspecific symptoms. Often patients get a cardiac workup before people start to think about the lungs. And so this group of patients suffers from significant delays in diagnosis. All right, so then how do we go on to then classify and diagnose these groups of conditions? So interstitial lung disease and pulmonary fibrosis, these are terms that are sometimes correctly and incorrectly used interchangeably, but nonetheless, both of these terms are not diagnoses. They're umbrella category terms that encompass a heterogeneous group of disorders of more than 100, and they're really put together in these groups of conditions because of similar clinical, radiographic, physiologic, and or pathologic manifestations. And there is somewhat of a misnomer when we refer to them as interstitial lung diseases. It doesn't just involve the interstitium. Many of these diseases involve the peripheral airways and the alveoli as well. But nonetheless, these conditions, probably because originally they were uncommon and rare, were lumped all together due to common clinical presentations of shortness of breath, abnormal imaging studies, restriction on pulmonary physiology, and an increased AA gradient. And up until the 1990s, these groups of conditions were generally thought to be very similar. And so lung fibrosis due to arthritis or lung fibrosis due to smoking or cases of fibrosis in which they couldn't identify the etiology were all generally thought to be the same condition. However, in the 1990s, people started to recognize and understand that these different etiologies looked different underneath the microscope. So the histopathologic appearance of these conditions looked different. And people started to wonder if that had clinical implications. And so when we looked at these diseases as a single entity, up until the 1990s, all patients were given a poor prognosis with a median survival of 3 to 4 years. However, when they started looking and differentiating patients by their underlying histopathologic pattern, you can start to see different patterns emerge in terms of survival. So those who had a UIP pattern of disease had a far worse survival compared to others who had non-UIP forms of interstitial lung disease. And this understanding really shaped the way we currently think about these groups of conditions. And so here's the current clinical classification for our groups, for this group of interstitial lung diseases. There are 4 main buckets of disease. The first bucket is that related to exposures. So certain occupations like being a coal miner or having certain hobbies like woodworking or being a mechanic puts you at risk for having interstitial lung disease. Other environmental exposures, for example, exposure to birds or organic antigens like mold, put patients at risk for having a condition called hypersensitivity pneumonitis. And of course, certain medications are associated with drug toxicity and interstitial lung disease. The second main group of conditions are those of the idiopathic interstitial pneumonias, IPF being the most common, but there are 7 other conditions within this category. Their names and their acronyms are listed below. The third category is that of the connective tissue diseases. We know that connective tissue diseases are multi-organ diseases, and in the lungs, they can manifest in the form of interstitial lung disease. And I've listed the most common connective tissue diseases associated with ILD. And finally, the fourth category is basically a miscellaneous category, but includes important conditions like sarcoidosis, Langerhans cell histiocytosis, and lymphangioliomyomatosis. So if we try and estimate the relative distribution of these specific interstitial lung diseases in the United States, it probably looks somewhat like this. So idiopathic pulmonary fibrosis probably affects 20%, chronic hypersensitivity pneumonitis, which is again that environmentally induced interstitial lung disease, 20%, connective tissue disease, ILDs as a whole affecting 20%, and sarcoid 20%. The remainder are made up of the miscellaneous causes of interstitial lung disease. So I want to pause here and really emphasize that interstitial lung disease or pulmonary fibrosis are not specific diagnoses, and there are reasons we should pursue a specific diagnosis for patients who have these findings. Many forms are treatable. Treatment depends on the diagnosis, and certainly prognosis depends on the diagnosis. So how do we go about getting to a diagnosis for our patients? Well, the first thing is that chest X-ray is not a useful imaging modality for differentiating different forms of interstitial lung disease. So you can see here 4 chest X-rays, all from different patients with different types of interstitial lung disease. And you can see that you can't make heads or tails of the interstitial lung disease using chest X-ray. Instead, we've really used CT scan imaging, and in particular, high-resolution CT scan imaging. And in these next 2 slides, I'm going to share with you why we favor high-resolution CT scan over standard non-contrast CT scan in the diagnostic evaluation of someone who has interstitial lung disease. So you can see these are representative images from the same patient. On the left-hand side, you can see a standard non-contrast CT scan taken in the supine position, where there's evidence of ground glass opacities and maybe some reticular change down at the base. However, with high-resolution CT scan imaging, we obtain prone images, and you can see that all of those abnormalities resolve, suggesting that the findings on the supine images were really dependent atelectasis. The second advantage of high-resolution CT scan over standard non-contrast CT scan is demonstrated here. You can see on the left-hand side is the inspiratory image that comes with a standard non-contrast CT scan that demonstrates relatively normal parenchyma. On the right-hand side, you can see the expiratory images that are obtained using the high-resolution CT scan protocol. And now you can observe that there are differential regions of lung attenuation. Some areas of the lung are more dense than others, suggesting air trapping and the presence of small airways disease. And so high-resolution CT scan really is the key here. The pattern of abnormality on the HRCT scan can suggest a specific interstitial lung disease. High-resolution CT scan findings guide subsequent diagnostic tests, and high-resolution CT scan findings can be sufficient for diagnosis in a handful of patients. And so once high-resolution CT scan is obtained, we employ a multidisciplinary approach to diagnosis. And this has become a gold standard based on this publication from 2004, in which a series of steps were taken to look at diagnostic agreement and confidence with varying and increasing levels of discussion between clinicians, radiologists, and pathologists, and also increasing levels of information provided anywhere from CT scan, clinical data to lung biopsy. And what was observed is that the best agreement and the highest diagnostic confidence came when there was a discussion between all the parties, the clinicians, the radiologists, and pathologists, each speaking to their areas of expertise. And so this has become our central approach to the diagnosis of interstitial lung disease. It's a collaboration between pulmonary, rheumatology, radiology, and pathology, really integrating the patient's history, risk factors and exposures, their lung function data, their CT scan findings, their blood tests, and sometimes their lung biopsy results to truly come up with a multidimensional and multidisciplinary approach to their diagnosis. And so the key points on diagnosis is that interstitial lung disease or pulmonary fibrosis, again, is not a specific diagnosis. High-resolution CT scan is the imaging modality of choice for unexplained parenchymal lung disease, and multidisciplinary diagnosis is the gold standard. So now I'm going to transition and share with you some advances in treatment and research in interstitial lung disease. And so we're now going to focus on treatment of one particular condition, the one that our case had, that of idiopathic pulmonary fibrosis, and review with you some key clinical trials that occurred between 2010 and 2014. As some of you may know, before 2010, we treated all patients with IPF with immunosuppression, a combination of prednisone, azathioprine, and N-acetylcysteine, or NAC. And this was largely the standard of care therapy up until 2010, based on this publication back in 2005. However, this standard of care treatment was tested in 2012. And what occurred in 2012 was the completion of the Panther studies, which was an NIH-funded consortium called the IPF Net that really tried to better understand standard of care therapy. And when patients were randomized to standard of care therapy compared to placebo, the study was actually stopped early because of increased death and hospitalization in the combination therapy arm. And so as a result of this, we understood that the treatment that we had been doing up until 2010 was hurting our patients. And it was really an important discovery. Thankfully, along the same time period, there were other clinical trials that were being performed. So pirfenidone, an antifibrotic, was being studied in the Capacity 1 and 2 trials and the Ascend trial. And nintedanib, another antifibrotic, was studied in the Impulsus 1 and 2 trials. And both of these antifibrotics were shown to slow decline in forced vital capacity over a 52-week time period by about 50%. And so both pirfenidone and nintedanib were discovered to slow decline in forced vital capacity. This led to a large paradigm shift in our treatment for IPF. We stopped immunosuppressing our patients and started prescribing antifibrotics following FDA approval in 2014. So antifibrotics, as I showed to you, slows disease decline in IPF. The indications for these existing agents are expanding, so you may be seeing it used in some non-IPF interstitial lung diseases. But it's important to remember that antifibrotics are not curative. They don't actually make patients feel better in terms of their symptoms of cough or shortness of breath. And these medications require blood monitoring and management of common side effects. And so because these antifibrotics were a good start, but certainly not the holy grail for our groups for this particular condition, there's a lot of activity in terms of phase 2 and phase 3 clinical trials in IPF. And so here is a list of active phase 2 or phase 3 clinical trials in this disease space. What you can see here is that they're targeting lots of different pathways: immune dysregulation, alveolar epithelial cell dysfunction, fibroblast proliferation, and extracellular matrix deposition. So really trying to look at all sorts of different angles for treatment of this condition. And so I think the future of IPF treatment in the next several years is going to look very different. We're going to be talking about things like combination therapy, much like the PH world has already done. We're going to be starting to use novel therapies, infusion therapies for our condition, perhaps inhaled therapies or novel mechanistic therapies that are targeting specific pathways. And finally, what I think is personally most promising is the concept of tailored therapy. So using the patient's genetics and blood biomarkers to determine which treatment might be best for your patient with IPF. So the key points on treatment here are that immunosuppression is not recommended for the treatment of IPF. Antifibrotics are now standard of care for IPF, but clinical trials remain critical. So now I'll transition into some research highlights, some work that we're doing here on the Anschutz campus in really two main categories. The first is that of refining diagnosis, or another way to think about that is understanding disease phenotypes, and then earlier diagnosis. So in order to have a discussion about refining diagnosis, we have to talk about the differences between pattern and diagnosis. And this is something that's plagued our field for a long time, as patterns have often been used interchangeably with diagnosis, and that's incorrect. So to try and highlight this, I decided to try and make something that would make a little bit more sense than jumping into the UIP pattern. So if I ask you to think about an animal with a hexagon skin pattern, and without giving you any other information, some of you might think of a giraffe. Others of you might think of a turtle, and then yet others might think of a snake. So here it clearly outlines that pattern does not equal diagnosis. And same with this usual interstitial pneumonia pattern. UIP pattern has sometimes become interchangeable with IPF, and that's actually not the case. UIP is a pattern that's seen on radiology and histopathology, but it does not always equal a diagnosis of IPF. And in fact, many of our common interstitial lung diseases share with this pattern. So rheumatoid arthritis-associated interstitial lung disease and chronic hypersensitivity also can have this usual interstitial pneumonia pattern of disease. The difference in these other diseases is the prevalence of the UIP pattern. So patients with IPF, of course, 100% of them have the UIP pattern, but it can be seen in 50% or more of patients who have rheumatoid arthritis-associated interstitial lung disease, and is probably seen in up to 20% of patients who have chronic hypersensitivity pneumonitis. And it's because of these similarities that we've become interested in the relationship between idiopathic pulmonary fibrosis and RA-ILD. And we've been looking at it from an epidemiologic, genetic, and biologic perspective. So what really got us interested was the observations of similarities in clinical phenotype. So patients with IPF and RA-ILD are diseases of the aging population. They affect men more than women. They affect smokers more than non-smokers. And both diseases are experiencing an increasing incidence over time. And of course, UIP pattern is seen in all of patients who have IPF and in most of patients who have RA-ILD. The other thing that we've observed is if you look at the RA-ILD patient and determine who has the UIP pattern and who does not, you can see that the RA-ILD patients with a UIP pattern have a survival curve that mimics that of idiopathic pulmonary fibrosis and is better than that of those who have RA-ILD without a UIP pattern. And so this got us interested in learning, trying to identify other similarities, and our first stop was in genetics. So the MUC5B promoter variant, as many of you know, Dr. Schwartz and his team identified this as a significant genetic risk factor for both familial and sporadic forms of the disease. The minor allele frequency is 0.38 in patients who have IPF compared to 0.09 in controls. And this MUC5B variant has been associated with unique biologic and clinical phenotypes. And this finding has been replicated in numerous studies since its original publication. So in RA-ILD, our hypothesis was that the strongest risk factor for the development of IPF, that of the MUC5B promoter variant, would also contribute to the risk of ILD among patients with RA. So we performed a genetic case control association study. ILD status was assessed by high-resolution CT scan for most of the patients with RA. All subjects were genotyped for the MUC5B promoter variant. And the discovery step included a French cohort. The replication step included subjects from Japan, Mexico, Greece, the Netherlands, China, and the United States. And in our combined analysis, we had 620 RA-ILD subjects, 614 RA without ILD, and over 5,000 controls. And here are our primary findings. So you can see here on panel A, this is comparing RA patients without ILD compared to controls. And you can see there is no increase in the minor allele for MUC5B across the different cohorts. And then in panel B, you can see the RA-ILD cases, so those with interstitial lung disease compared to controls, that they were more likely to have the minor allele for MUC5B compared to controls. And this was present in the French discovery cohort across the multi-ethnic replication and then the combined analysis odds ratio at the bottom. So then we looked a little bit further. So among RA patients, we looked at the contribution of MUC5B to ILD susceptibility. You can see the odds ratio for RA-ILD versus RA-no-ILD was 3.1. When we looked further, we identified that this was really driven by those with the UIP pattern. So again, we distinguish patients with RA-ILD by the presence or absence of this UIP pattern. If they had UIP compared to RA without ILD, that odds ratio was 6.1. Those who had ILD without a UIP pattern compared to no ILD, there was no difference in the prevalence of the minor allele for MUC5B. And then you can see that bottom odds ratio is comparing within RA-ILD cases, those with UIP compared to non-UIP. And we are currently exploring a lot of similarities and differences in biology. I don't have time to share with you a lot of this data today for time, but we're identifying very interesting similarities and differences in terms of proteomic profile, transcriptomic profile. We're also finding similarities in telomere length reduction, as well as molecular markers of senescence. And so more to come on this in the future. So it might seem a little bit academic to really, spend your life looking at similarities between different causes of UIP pattern, but I do think that there are actual significant clinical implications for this. And the reason for that is treatment. So treatment, as I mentioned before, really depends on the underlying diagnosis. So when a patient is diagnosed with idiopathic pulmonary fibrosis, we no longer give them immunosuppression because we know that's harmful for them. We instead give them antifibrotics and enroll them in clinical trials. All of our other non-IPF interstitial lung diseases like rheumatoid lung disease or hypersensitivity pneumonitis are given immunosuppression and clinical trials if available. And what we don't know is if that harm related to immunosuppression in our patients who have IPF are translatable to our patients who have non-IPF forms of UIP lung disease. And so this is an active area of investigation. So our ongoing questions related to this is really trying to understand what makes the relationship between IPF and RA-ILD unique, given that these similarities do not appear to exist with other autoimmune-related interstitial lung diseases, and what is the role of RA in the development and progression of RA-ILD. And finally, what are the implications for treatment? Does the underlying biology or histopathology make a difference in how we treat patients with this condition? Is there an impact of immunosuppression in RA-ILD? And if so, it would certainly be very difficult and problematic to reconcile given the underlying rheumatoid arthritis. And then what is the role of antifibrotics in RA-ILD? So now I'm going to transition and talk to you about some work that we've been doing in early diagnosis. So in general, we diagnose interstitial lung disease too late. And if we think of this timeline or sequence of events that occur in patients who end up in our clinics, we recognize that there is an at-risk period, a time in which they don't have disease, but are considered to be at higher risk because of their family history of pulmonary fibrosis or certain autoimmune conditions that place them at risk. We know that if we start looking, we can start to find disease. And so we can identify radiologic abnormalities in patients with very few symptoms. But we know that even these radiologic abnormalities are concerning because it's associated with all-cause mortality. And unfortunately, we identify patients when they already have significantly established disease. At the time of diagnosis, they're very symptomatic. They have that poor prognosis, and there are few therapeutic options, and there's nothing that reverses the scar that's already developed. And so we've been looking at rheumatoid arthritis patients in our RAPID study. So rheumatoid arthritis patients at risk for interstitial lung disease. RA is the most common inflammatory arthritis, and interstitial lung disease is a common extra-articular manifestation of RA, affecting anywhere from 10 to 40% of patients. And what's been observed is that death from RA-ILD is increasing. Respiratory disease mortality is 2 to 3-fold higher in RA than in non-RA subjects. And we've observed higher death rates in RA-ILD compared to other connective tissue disease-associated interstitial lung diseases. And just to reiterate, we diagnose this condition too late. They come to us with a heavy disease burden, they're less responsive to treatment, and they're often not candidates for lung transplantation due to their comorbidities and extrapulmonary manifestations of disease. And so what we've done is we started a study to look at patients with RA who don't have known interstitial lung disease and really phenotype them and getting an extensive clinical history, getting an exposure history, assessing their RA disease activity and medication treatment history. And then we're studying their lungs by obtaining a high-resolution CT scan and getting pulmonary function tests, and of course collecting biologic samples including DNA and serum. And this has all been done in collaboration with Kevin Dean in the rheumatology department. And with our radiologists, they are interpreting our CT scans for us and identifying whether or not fibrosis is present on these screening CT scans. In those that don't have fibrosis present, they remain at risk, but there are patients who have early findings of subclinical lung disease. And here's a snapshot of some preliminary findings. So in the first 110 subjects that have been enrolled into this study, the average age is around 56 years of age, 20% are male. They all have normal lung function by forced vital capacity and diffusing capacity. Half are ever smokers, and the majority are positive for the anti-CCP antibody. They have very little shortness of breath as measured by the UCSD shortness of breath scale. This is a scale in which higher value equals more shortness of breath, and the highest value is that of 120. So you can see here patients have very few symptoms. And radiologic fibrosis, as determined by our radiologists and by consensus, is at 25%. And in this population, there are 22% that have the T allele or the minor allele for MUC5B. And when we look at predictors of subclinical RA-ILD, this is what we find. So predictors of subclinical or radiologic lung disease among RA patients include age, lung function, though remember the lung function is normal, so these are different degrees of normal lung function, shortness of breath, and the T allele for MUC5B is a strong predictor of subclinical lung disease in this patient population. And so we're hoping to use information like this to really determine who should get screened for interstitial lung disease. And with that, to try and better understand what the genetic and molecular features of subclinical RA-ILD are, and then to follow these patients over time to determine who really gets the established lung disease that's life-limiting. Can we identify which of these subclinical RA-ILD patients will progress? And if so, can we target early therapeutic options to prevent the progression to established disease? And while I don't have time to talk about this, I did want to share with you some other active areas of investigation. We've long been interested in comorbidity identification and management, in particular looking at the role of reflux and treatment of reflux in patients who have idiopathic pulmonary fibrosis. A newer area of investigation really involves disparities in care and care delivery. I have a fellow who's looking at the veteran population because we understand that there's a lot of issues related to disparities in care for that particularly vulnerable patient population. In addition, we know that care delivery is a problem for many patients, and access to care is a problem. Not every patient has the opportunity to go to a university center to get care, and so how can we improve that? And finally, we have a young faculty member who's focused on caregiver burden and trying to understand the impact of these lung diseases on their loved ones. And so I want to end with some final thoughts on our ILD program. Our mission really is to improve the lives of patients with ILD by focusing on the domains of clinical care, education, and research. So every patient that's seen in our clinic is offered a thorough assessment, provided disease state education by our nurse, and then also given the opportunity to participate in a registry. We know that registry participation is critical for rare lung diseases, and we're happy to provide that opportunity for patients here in our clinic. All of our new patient visits are then taken to our ILD multidisciplinary conference, where we discuss cases with pulmonary, rheumatology, radiology, and pathology to come up with a multidisciplinary diagnosis. And depending on the diagnosis, the patient is assessed for candidacy in ILD research, whether that's in an investigator-initiated study like I shared with you, or with clinical trials. And finally, we bring it back to the community. We work very collaboratively with our referring providers, both primary care providers and community pulmonologists, to provide comprehensive care for our patients. We also try and perform outreach to educate patients and the community about these groups of conditions, and also by providing education, not only by teaching others about these groups of conditions, but also by providing a non-ACGME ILD fellowship in order to train the next generation of ILD physicians. And so some practical tips to refer to our ILD program. We actually have a specific EPIC referral to interstitial lung disease. If you can't find the EPIC referral, you can refer to pulmonary and place the reason for referral as that of interstitial lung disease, and it will make it to our group. And then I told you the critical importance of the type of CT scan that's done in patients who have suspected interstitial lung disease. And here it's not referred to as a high resolution CT scan, but the EPIC order is CT chest ILD. And finally, I just want to say a lot of thanks to my fantastic team. I am blessed to be surrounded by a whole host of fabulous faculty colleagues, as well as trainees and staff who really make my job so much easier. I'm also lucky to have local and global collaborators who are tremendously fun to work with and who push me every day. And then we also have a lot of diverse funding agencies to help to support our work. And last but not least, I want to thank the patient. This happens to be Pulmonary Fibrosis Awareness Month, and it's because of the patients that we do the work that we do, and it's because of their participation in registries and clinical trials that we've made the advances that I've just described to you. And it's with their partnership that I think will really change the future of this really terrible group of diseases. And so in summary, I'll end with interstitial lung diseases are an important group of conditions associated with increasing morbidity and mortality. These terms, interstitial lung disease and pulmonary fibrosis, are not specific diagnoses, and work should be done to obtain specific diagnoses for our patients. Treatment is evolving, and finally, comprehensive and multidisciplinary approach to care, inclusive of clinical care, education, and research, are truly critical. And with that, I'll take questions.
Joyce, thanks very much. That was really terrific. as expected. And I really want to thank you for all the great work you're doing in interstitial lung disease, clinically and in terms of our academic mission. Let me start with a few questions related to diagnosis. Tell us where the 6-minute walk fits in, both in terms of specific diagnoses as well as prognostic implications.
Well, 6-minute walk testing, I don't really think of it as a diagnostic test to figure out which particular type of fibrosis a patient has. But certainly it's very important to identify unmet oxygen needs in our patient population. So oxygen desaturation is unfortunately not uncommon, and actually obviously more prevalent here at altitude than it was for me in San Francisco. And so it really comes, that piece comes in terms of comprehensive management of patients who have interstitial lung disease. Desaturation is bad, and I don't know if there's been publications looking at the, actually there have been publications looking at the extent of desaturation being associated with prognosis. And so I think it's just another marker for disease severity.
Mm-hmm. Okay. And the need for oxygen in terms of activities.
Exactly.
So tell us when a lung biopsy is needed, and especially when it's contraindicated.
Well, so yeah, sometimes we can't get to a diagnosis with clinical information and CT scan and blood work data. And in cases in which we can't get to a definitive diagnosis, then we consider surgical lung biopsy in those cases. But we want to make sure that the patient can tolerate a surgical lung biopsy. So, significant comorbidities, significant oxygen use, significant lung function impairment are all relative or definite contraindications for pursuing a surgical lung biopsy.
Mm-hmm. And when wouldn't you pursue it?
Would not pursue it. If you have a diagnosis based on the CT scan and the clinical history, you would not need to pursue a lung biopsy. And of course, if there are contraindications where you think they're going to have trouble related to the lung biopsy, then it's not worth the risks of biopsy.
Mm-hmm. Okay. And what about the histology that you get from a lung biopsy? There is quite a bit of variation in individuals, especially with IPF. Mm-hmm. I guess the question here is that variation due to different stages of disease in different parts of the lung, or is it due to different conditions?
That's a really great question, and I think that's where the multidisciplinary discussion becomes really important, trying to understand whether or not, the lymphoid aggregates that we see in a patient are typical of what we might see in somebody who has IPF, or are more exuberant and would necessitate a more extensive evaluation for an underlying autoimmune condition. And these are things that we can't glean from reports, and really talking to the pathologist in the context of the patient's clinical history, I think, become really critical.
Mm-hmm. Right. Tell us a little bit. Well, let me follow that question up. Have there been individuals where you get a second biopsy on them, and what kind of progression have you seen?
We very rarely go on to get a second biopsy. I can't think of many cases in which we would do that. Sometimes we have an opportunity to reassess diagnoses when patients have gone on to lung transplant, and we can look at explanted lung tissue and see the progression in that regard. But there are very few circumstances in which we would pursue a second surgical lung biopsy.
Mm-hmm. In terms of environmental forms of interstitial lung disease, what happens when you remove the environmental agent? Does it differ in asbestos-related lung disease versus hypersensitivity pneumonitis?
Yeah, so in hypersensitivity pneumonitis, it depends on kind of the stage at which you identify and diagnose hypersensitivity pneumonitis. We know that some patients present with a very acute phase where they have not had time to develop fibrosis, and so antigen mitigation and control of the environment can improve patients and without long-lasting consequences. Sometimes we see patients who've already developed fibrosis as a result of their ongoing environmental exposure. We still strongly recommend mitigation of any suspected antigen so that any driving, any antigen exposure is mitigated to reduce that inflammation. But sometimes patients, once they've developed fibrosis, will continue to have issues related to fibrosis even after the antigen is removed. So it's a little bit more complex once the disease has been in place for longer periods of time. For asbestosis, that exposure occurs 20 or 30 years before they're ever diagnosed with their pulmonary fibrosis. And so there is no antigen mitigation in that particular context, but certainly, things related to asbestosis include workers' compensation and disease progression, and so they have a whole different set of things that you'd want to address in those particular cases.
Good, good. In considering treatment for individuals with antifibrotics, how early do you treat individuals? What if they are asymptomatic but have radiographic evidence of UIP?
Yeah, that's a really great question. And I think there is probably some differences of practice depending on who you ask among the ILD community, but I would say the majority of us treat early. The reason for this, if your patient truly has a diagnosis of idiopathic pulmonary fibrosis, we know that it's an invariably progressive disease. And whether or not they have symptoms today or next month or a year from now, we know that long-term the patient will have progression. And so early treatment is recommended. Of course, this is always a discussion with the patient, what their values are and the risks and benefits of therapy. But I always offer it at the time of diagnosis, regardless of symptoms or how they were discovered to have disease.
Great, good. Two-part question related to autoimmune antibodies, autoimmune disease. What do you do with a patient with IPF who has high titers of rheumatoid factor versus one without? Do you change therapy related to that? And related to this bigger question, in interstitial lung disease, when you're working up an individual with idiopathic pulmonary fibrosis, what's the role of autoantibody studies?
So our current clinical guidelines in anybody who's suspected to have idiopathic pulmonary fibrosis, part of that evaluation, it's recommended that we get screening serologies. Those screening serologies include an ANA, a CCP antibody, a rheumatoid factor, and in the most recent iteration of the guidelines, inclusive of a myositis panel. The goal is to obviously exclude a known cause of interstitial lung disease. This gets to your first question about what do you do with a positive serologic test, and this is where partnership with rheumatology becomes very important. So a serologic test doesn't mean anything unless there is a clinical history or clinical findings to support an underlying rheumatologic diagnosis. So if an RF or a CCP is positive and the rheumatologist tells me there's no evidence of an inflammatory arthritis, we treat the patient and diagnose them with IPF. If the rheumatologist instead says, yes, there's evidence of an inflammatory arthritis and they have rheumatoid arthritis, then this changes our treatment approach. And the current standard of care treatment approach for RA patients, even if they have a UIP pattern, is that of immunosuppression. And right now, that just remains the standard of care until we know more.
Mm-hmm. Good. So you've said that these diseases are related to cigarette smoking. What's the relationship to air pollution, and is there any evidence at all that this is a disease that's increasing in incidence or related to urbanization of the population?
That's a really great question. There have only been a handful of studies that's looked at the role of air pollution in patients who have IPF in particular. One study showed an association between different particulate exposure and the development of acute exacerbations. Others have shown that the air pollution can be associated with lower baseline lung function, but was not shown to be associated with longitudinal change in lung function, though the study was short and had a small sample size. So I think certainly there must be a role for air pollution, but we have yet to figure out what that is.
Okay, good. And could you make some comments about coronavirus and its effect in this population of individuals with interstitial lung disease, and also the possibility that it may be a future cause of interstitial lung disease?
Yeah, so thankfully, we have only seen a handful of cases of coronavirus infection in our patients who have interstitial lung disease, and many of them have done generally well with the infection. And I don't know if that's because these patients are already used to, hand washing and very good infection control and prevention, or if there is something with the biology of the disease that makes them less susceptible or to have less severe infection. But there is a registry study that's ongoing to better understand the impact of coronavirus infection on these groups of individuals. And then in terms of the future, yes, I don't know what we're going to see down the line and how much lung fibrosis we're going to see following coronavirus infection. And certainly that will be an area of active investigation for many investigators moving forward. So more to come probably in a few years.
Okay. Joyce, thanks so much for your comments and for educating all of us about interstitial lung disease. This has been a really great in-depth review and has heightened, I think, the awareness of all of us to the importance of interstitial lung disease. Thanks very much.
Thank you.